as far as laboratory confirmation is concerned, we need to do, RT-PCR, TrueNAT is also available, and antigen tests are available. But what are the different laboratory parameters that can tell you about severity of COVID-19 infection? This is the lymphopenia. Any patient who has persistence of lymphopenia, lymphocyte count less than 10, gives you an enough indication that there is prolonged viremia, and immune response is still not activated enough. Any patient with the elevated liver enzymes, inflammatory markers like C-reactive protein or elevated ferritin levels also gives you an idea of severity of the COVID-19 infection. Increased D-dimer levels also tell you about hypercoagulable system. COVID-19 infection is an hypercoagulable system. That is basically due to the endothelial cells which are affected. One Willebrand factor is also inhibited. So that's why there is more and more production of the coagulation factors. More and more platelets get adhered to the endothelial cell. There is more formation of the thrombin. Even the fibrinogen levels also are very less in this patient. So as we know that COVID-19 is in hypercoagulable state, the monitoring of the D dimer is very, very important in these patients. The thrombotic complications are also very less. The thrombotic complication in the form of stroke, myocardial infarction, or bowel ischemia with mesenteric thrombosis, cavernous sinus thrombosis, or thrombosis of the digits and thrombosis of the other vital organs like the renal artery thrombosis, renal vein thrombosis, hepatic vein thrombosis, and portal vein thrombosis incidence is also being documented. And we also had patients with the bowel ischemia, liver dysfunction, and all. So that's why the monitoring of D dimer is very, very important here in these patients. And we have also seen IL-6 levels. IL-6 level is an inflammatory mediator. Higher the IL-6 level, higher is the mortality. So that's why frequent monitoring of IL-6 is also important. But so all the hospitals may not have IL-6 monitoring, but then we have to have the CRP or ferritin levels can give us enough idea about inflammatory markers if the IL-6 levels are not monitored. Elevated CPK, creatinine kinase level, also gives us a clue about possible muscular injury to this patient. So, but the diagnosis is viral PCR through nasopharyngeal and oropharyngeal sample. Two samples, one from nasal and oral sample, should be collected to actually diagnose COVID-19 infection. As we know that how the COVID-19 infection spreads. First is a symptomatic phase. First 5 days are asymptomatic. Okay, and then the patient becomes symptomatic fifth day onwards, sixth day onwards. The symptoms will be cough fever, or fatigability and all. And that is the point of time where IgM antibodies become detectable. Okay, and that gives you a clue that at least 7 days have surpassed, and patient has already gone through that asymptomatic phase or symptomatic phase. Okay, and then we see the production of IgG 14th day onwards. Means the second week onwards, sometimes 10 to 12 day onwards, you will see that the production of the IgG is evident, and then that is the phase of recovery where the patient starts recovering. The presence of IgG with mild infection gives an enough indication that there is a possibility of recovery, but the resurgence of infection may be possible. But that gives you enough clue for clinicians like us whether the patient is recovering or not. If the IgG levels are detectable, probably the patient is recovering, and the IgG levels remain in the blood and provides long-lasting immunity. But with this COVID-19 infection, IgG levels have also become undetectable after 3 months or 4 months, or sometimes some patients have IgG levels being detectable for 6 months or a year or also. So, but in some patients, the IgG response is also very sluggish. Some patients have no IgG production. That's why they are at the risk of acquiring infections on multiple occasions. So that's why the identification of the antibody gives you enough clue for some of the other medications like plasma therapy that we give in some patients who are affected with COVID-19 infection, especially those patients who come up in the first week or so. The plasma therapy can also be instituted if the antibody production is not seen in patients. So that's why those patients where IgG production is not seen, these patients are likely to have recurrent infections, and these patients should have good control over the avoidance of the transmission. So typically the chest X-ray presentation is peripherally located haziness. You will see it is never centrally located. For few cases, even central presentation is also seen. But a COVID-19 infection is basically a peripheral subpleural consolidation kind of a presentation. Initially, they will have ground glassing. They may present with local patchy infiltrates initially, which will become confluent later on and have more haziness, which becomes more evident once the viral illness becomes more prolonged. So it can be unilateral, it can be bilateral, but bilateral presentation is generally 70 to 75%. Unilateral presentation may be in 25% of the patient, which is basically unilateral presentation is good for some patients. Okay, which lung is affected, that also contribute to the significant hypoxemia. If the patient has right lung affected, probably they will have more significant hypoxemia and they will have more breathlessness and more symptomatic. Okay, and interstitial abnormalities like interstitial thickening, fissural fluid is also seen in some of the 5% of the patients. And pleural effusion is also seen in some patients, but it is very uncommon finding. Okay, basically it is seen with bacterial infections, but some cases of viral infection with the secondary bacterial infection can have presentations of the pleural effusion. So if the patient has pleural effusion, consider secondary bacterial infection, or patient has a third spacing. Okay, these assumptions can be drawn. CT chest is seen, and it is more sensitive marker, sensitive diagnostic modality for confirmation of COVID-19 infection. So 86% of the patients will have CT chest finding, and then lung involvement is proportionate to the severity. So higher the lung involvement, higher the symptom, patient is likely to be symptomatic. Okay, that is how CT severity score is more important in this patient. Any patient with a CT severity score 5 to 6 or 7, we call it as mild infection. Up to 8, we call it as mild infection, but 8 to 14 or 15, we call it as moderate affection of the pneumonia. And if it is beyond 14, we call them as severe pneumonia or ARDS kind of a picture. So ground glassing is seen in 98%, 99% patients will have ground glassing. Ground glassing is something like some haziness, which is not very opaque. But when it becomes opaque, that tells you that there is a consolidation, presence of consolidation. Okay, so ground glassing is especially seen in almost all the patients. The presence of ground glassing also gives you enough clue. Even if the patient may be RT-PCR negative, the ground glassing gives you enough clue that this patient is likely to be suffering from COVID-19 infection. And then some patient may have reticular pattern. Consolidation is a later part of later phase of COVID-19 infection. Okay, so basically second week onwards or 10th day onwards, the consolidation comes up. Especially after first week, the consolidation is seen. If there is a presence of consolidation, it means the infection is at least more than 7 days or so. And those patients with the severe COVID-19 infection, they will even have crazy paving or tree in bird kind of appearance on the CT scan. So the sensitivity of these features that I have already enumerated is 97%, but the specificity is 25%. It is quite sensitive.